So DeQuervain's Tenosynovitis is my clinical pattern, and it's an overused inflammatory condition that affects the tendons that make up the anatomical snuff box of the wrist. These tendons include the abductor pollicis longus and the extensor pollicis brevis. So when you overuse that wrist joint, it can cause chronic myxoid degeneration within the synovium, and it can thicken the tendon sheath. This degeneration can cause a connective tissue in the area to be replaced by like a gelatinous substance, and it can cause increased deposits of fibrous tissues, which can cause the tendons in the anatomical snuff box to thicken significantly. That thickening can cause the abductor pollicis longus and extensor pollicis brevis tendons to be entrapped, which also presents with inflammation and pain. So again, the mechanism of injury is normally an overuse injury from repetitive hand and wrist motions. And some of these activities that can cause it can be golf, repetitive use of hand tools, repetitive office tasks like typing on a computer, or if you're a mother or a father, repeatedly lifting a child using their thumbs abducted. Some signs and symptoms are pain and tenderness along the lateral side of the wrist by the anatomical snuff box, and this pain can radiate up the forearm. They may experience difficulty with gripping different objects and with swelling. Some contributing factors include the occupation of the patient, like if they do a lot of office work, their hobbies and participatory activities, and based on one of my references, a reference SMP cluster on chromosome 8 is also linked to this tenosynovitis. When it comes to the physical examination, they'll have pain extending and abducting the first digit. They also can experience wrist pain on the radial side with most thumb and wrist motions. They'll have decreased range of motions actively in all the motions of the first digit and of the wrist due to pain and inflammation. If it's progressed enough, passively they may experience decreased range of motion in the CMC joint of the first digit because of those anatomical changes I was talking about earlier to the tendons and the anatomical snuff boxes. Resisted testing might be implemented, but because of the pain, it might not be helpful. They'll either provide strong and painful or weak and painful cut. For accessory range of motion, for anterior to posterior and posterior anterior gliding of the radial carpal joint, you can assess it. It could be limited due to the anatomical changes, but a lot of times it can vary based on how this disease has progressed. For special tests, Finkelstein's is like the go-to. So we learned about this earlier. You take your thumb, you put it in your fist, and you ulnar deviate. And if it reproduces their familiar pain, then it's a positive test. Some differential diagnosis is scaphoid fracture, osteoarthritis, radial styloid fracture, and Wartenberg syndrome. The prognosis is usually good depending on the interventions implemented. And a big thing is whether the patient is re-irritating those tissues with their activities and their participatory activities as well. We also have to look at the tendon healing time frame. It can take from 21 to 28 days to a year for these tendons to fully heal. With controlled loading, the pain should gradually decrease and the function should gradually increase. Management, you can do modalities for inflammation and pain, like ice. Ultrasound can be used with a 3 megahertz frequency. Heat may also be used to relax the muscles in the area, which can help reduce the pain. Big things, activity modification. Manual therapy, you can use light effleurage and joint mobilizations if there's decreased motion in that CMC joint. For a range of motion and stretching, you want to slowly progress these exercises because you want to loosen the radial carpal and the CMC joints. You can do a wrist extensor stretch, wrist flexor stretch, or bring the CMC into adduction and flexion to help stretch these tendons out. And for strength, you can strengthen the wrist extensors and flexors as long as as well as the abductor pollicis longus and the extensor pollicis brevis. And then depending on the phase of healing they're at will determine if you're doing iso, eccentric, or concentric. You can use NSAIDs to help decrease the possible edema and inflammation at the joints. And surgery can be implemented if conservative management is not working. And it'll basically, if those tendons are entrapped, they'll make an incision to free up those tendons. And that's my clinical pattern.